My name is Vivian Tsai, and I'm a PGY inpatient pharmacy resident at Prisma Health Richmond Hospital. Today, I'll be sharing the key results of my project on predictive factors for treatment success in patients with non-tuberculosis mycobacterial or MTM infections. This project is funded graciously through Prisma Health grant and aid. MTM organisms are typically found in the environment. Individuals who are immunocompromised or who have lung disease are at high risk for acquiring pathogenic MTM infections. The treatment of MTM infections requires long duration of therapy, resulting in high expense, unwanted side effects, and increased risk for morbidity. Current gaps in literature include variability in the distribution of MTM organisms in different parts of the United States, as well as limited data concerning their susceptibility pattern. Additionally, there are limited evidence describing patients' MTM treatment outcomes, specifically the factors that could play a key role in influencing the treatment trajectory. The primary endpoint of this study was to identify predictors of favorable treatment outcome, and that is defined as physician-guided cessation of therapy at any time due to clinical improvement. Key secondary objectives are listed here for your reference. This was a retrospective single-center study that included adult patients with a positive MTM culture between January 1st of 2010 to June 30th of 2020. Key exclusion criteria are listed here for your reference. For primary outcome, a univariate followed by multivariate logistic regression analysis were utilized. We screened a total of 290 patients. Of these, 250 patients make up our microbiological cohort, and 195 patients were included as efficacy and safety cohort. Of the 195 patients, only 78 patients actually received treatment, and they're included as the final cohort for our primary endpoint analysis. Of the 78 individuals who were treated, 60% had a favorable treatment outcome, whereas 40% had an unfavorable treatment outcome. The most common reasons for unfavorable treatment outcome are listed here for your reference. In terms of baseline characteristics, our patients are predominantly non-Hispanic Caucasians with pulmonary MTM infection as their source. Additionally, those with an unfavorable treatment outcome tend to be underweight and have a lack of insurance coverage, and these are statistically significant from the favorable group. Proportional comorbidities was well balanced between the two groups. However, those with unfavorable treatment outcome tend to have a higher incidence of prior TB treatment and a history of asthma. The epidemiology data show that MAC is the most common organism observed in our cohort, followed by our rapid growers, which include M. abscessus and M. fortunum, as well as M. chelonae. And this is very consistent with the prior epidemiology studies. This table illustrates the results of our univariate analysis for predictors of favorable treatment outcome. Antibiotic change not due to therapy escalation or de-escalation is associated with 5 times likelihood of achieving a favorable treatment outcome, while more than 5 antibiotic changes, underweight, uninsured, and history of asthma are variables associated with unfavorable treatment outcome. When evaluating predictors using a multivariate regression model, antibiotic change not due to escalation or de-escalation of therapy is associated with 8 times likelihood of achieving favorable outcome. Furthermore, private insurance also increases probability of achieving a favorable treatment outcome by 6-fold. In this cohort, we observed that 60% of individuals had at least 1 antibiotic change. And the most common reasons for antibiotic change include adverse drug reaction and susceptibility. This table represents the susceptibility profile of the isolates observed in our cohort in the form of antibiogram. The percentage shown here is the percent susceptible. Overall, the first-line antibiotics remain susceptible to MAC, whereas M. abscessus is highly resistant. This suggests that the treatment of M. abscessus could pose great challenges in terms of a relative flexibility when choosing the best antibiotic regimen. Key study limitation include that it is a pretty small sample size, and not all isolates were tested for susceptibility, and it is predominantly pulmonary MTM infections. Therefore, generalizability to other sources of MTM infections is limited. In conclusion, the key predictors of favorable treatment outcome found in our study include antibiotic change not due to escalation or de-escalation of therapy, as well as having adequate insurance coverage. We observed that MTM treatment is rather complex, requiring multiple antibiotic changes, putting individuals at high risk for adverse drug reactions. Furthermore, our local susceptibility pattern indicated a suboptimal susceptibility profile for M. abscessus. Overall, this study highlighted an important key point, and that is the complex nature of MTM treatment requires collaboration with both ID physicians as well as ID pharmacists in order to minimize patients' risk for undesirable drug-related adverse side effects, while optimizing antibiotic regimen to achieve the most optimal prognosis. Additionally, individuals without adequate access to drug would also need special attention from our interdisciplinary team with treatment optimization, as it is a key factor for favorable treatment outcome found in this study. Currently, we're working on collecting follow-up susceptibility data to evaluate the influence of these organisms on antibiotics over time. We're also pursuing a patient satisfaction survey to evaluate patients' overall attitude towards their MTM management in order to minimize potential treatment barriers. Lastly, we hope that this study results will help us inform a MTM clinic that's primarily driven by pharmacists with the collaboration of our ID physicians. This brings us to our assessment question. What are the factors associated with successful treatment outcomes in patients with MTM infections? And private insurance would be the right answer. Thank you for your time and attention, and I look forward to any questions that you may have.